So I'm going to be talking today about bone health and the definition of osteoporosis, some of its causes as well as treatments, and how some cancer treatments can impact bone density. We'll also be discussing steps, both medicine as well as nutrition, that we can take to help prevent bone loss. Oh gosh, there we go. Okay, so bone is a living tissue. It is constantly remodeling, and most of us think of our bones as static, that they don't really change after childhood. But in reality, our body is constantly remodeling bones by destroying old bits of bone. And that process is called reabsorption. And then it lies down new bone tissue in response to stresses throughout our life. So as long as we're living, our bones are able to make new bone. As long as we're stressing our bone and telling our bones to make new bone. So there are two compartments of bone, and they are the cortical bone, which is the outer cortex of the bone, and the trabecular bone. And the outer cortical bone makes up 90% of 80% of our skeletal mass, whereas the trabecular bone makes up just 20%. The greater proportion of the peripheral skeleton is the cortical bone. That's the 3-layer protective outer shell around every bone in our body. And that's the real hard calcified bone. Whereas the trabecular bone is the interior scaffolding. It's only 50 to 25% calcified, but this is our bone that is our shock absorber. This helps to for us to do compressive type of movements without breaking our bones too quickly. And so those are the two types of bone that we have. So these are the essential functions of our bones. Our bones help to protect our internal organs. They store and release fat, especially our triglycerides. In the bone marrow, it produces our blood cells. It stores and releases our minerals, facilitates our movements, and it supports the body. So our bones are very important, and we need to try to protect those throughout our lives. Remodeling stages. So on this slide, we can see two graphs of bone density over the course of our human life, both for the female, which is the pink line, and for males, which is the blue line. You can see that between the years 0 and 10 years old, and 10 and 20 years old, and even all the way up to 30 years old, in those first 3 decades of life, the bone density rapidly increases until we reach our peak bone mass in our young adulthood. There's then in both graphs for the male and female a period of stability where bone density essentially remains approximately at its peak bone mass. And then you'll notice that the graphs start to diverge somewhat. The male graph shows that the density slows. Density slowly starts to decline after the age of 50. And in the female graph, however, you will notice that there's a sudden drop off around that same age between 50 and 60 before the slope of the line starts to straighten out again and essentially matches or goes parallel to the male density. That dip in the female, that pink line, is correlates to female menopause. And that's when our ovaries are no longer making estrogen and the body's estrogen starts to drop off significantly, which will drop off our bone density, making us much more prone to osteoporosis in our postmenopausal state. So, but note, however, that both men and women, it's absolutely normal for the bone density to decline through the second half of our lives. This means that a normal 90-year-old man or woman would have half the density of a 40-year-old. So the reason why this graph looks this way has to do with the natural stages of our body's bone physiology, the balancing of bone generation and breakdown, noting the rapid increase early in life, then the stability with our peak bone mass in our early adulthood, and then slowly dropping off in the second half of our lives. All right. So there's two types of specialized cells that help with this remodeling process. These are the osteoclasts. And you can see here in this microscopic photo of the bone, these osteoclasts are the large purple cells at the front of the bone. I'm not seeing half of my computer on that right-hand side, so I'm kind of trying to remember where this is. These osteoclasts, those big purple cells, they dissolve the bone, and they are making way for the osteoblasts, which are the bone builders, the smaller cells you see there that are coming in from behind, and they help those osteoblasts to lead the way to build up new layers of bone. So the osteoclasts will dissolve the bone and the osteoblasts will build up the bone. Now, this process occurs in part in response to stresses, such as if you were suddenly to take up a new sport like tennis or weightlifting. Our osteoclasts and osteoblasts would immediately go to work to remodel your bone to make a better fit and make it stronger for that new activity. So osteoclasts and osteoblasts are working in combination with each other, but they don't always exist in equal balance. The osteoclasts can either break down bone more quickly or equal to or even less quickly than the osteoblasts can lay it down. So as people age, the osteoblasts are not able to keep up with these osteoclasts. And so we can easily lose more bone quicker than it can be replaced. And that leads to osteoporosis. So let's recall the graph in my previous slide where in the early stage of life, there's a rapid increase in bone density. And that's when the osteoblasts are working really hard and building really a bone very quickly. And then let's see, and then that's when in middle life, we see that stable bone. That's when the osteoclasts and the osteoblasts are approximately equal to each other, in balance with each other, where they're breaking down and building. And then later on in our second half of life, the osteoclasts start to work faster than the osteoblasts, and that's when we start to lose our bone density over time. And because of the imbalance in the second half of our life, over time, our bones can become brittle and porous. And you can see that this can lead to the development of osteoporosis. In this picture, we can see 3 vertebral bones. The vertebral bone on top shows a normal bone density, where the strands or the struts in the trabeculae, in the bone or the trabeculae, are thick and adequate, and they can maintain the strength or the hardness of that bone. In osteoporosis, however, as you see in the middle vertebrae, because there's so much breakdown in the bones start to become more porous and weak, and they can easily collapse, which you can see here in the bottom vertebral bone, which shows a vertebral compression fracture. Osteoporosis, for most of its course, is an asymptomatic condition, meaning that people do not usually feel the thinning of their bone. And because of this, osteoporosis is oftentimes called a silent disease. It's diagnosed only after someone experiences a fracture after a minimal trauma, such as walking in your garden and falling in your garden, or sitting down too hard in a chair and suddenly having a fracture in your spine. Just like in this picture here at the bottom vertebrae. Those types of osteoporosis fractures, they're called insufficiency fractures. And these are oftentimes the first sign that a person's bone is aggressively thinning and might have osteoporosis. So the question is then, how do we look for osteoporosis and who do we need to test? Well, the National Osteoporosis Foundation advises that every woman should get a baseline bone density at the age of 65. For men, I believe the age is also 65. But the risk factors for more early onset osteoporosis include many of those listed here, including low body weight, which would be more weight under 127 pounds, long-term smoking or excessive alcohol intake, chronic malnutrition, family history, many of these that are listed here. Now, medical conditions can also increase osteoporosis risk, such as autoimmune conditions, including inflammatory arthritis or diseases that require long-term steroids like prednisone, which can quickly lose bone at a greater loss than normal. The hormone-driven cancer therapies in breast and prostate cancer also increase risks for osteoporosis. Endocrine therapies include any therapy that lowers estrogen and testosterone levels. These medications cause a sudden drop of bone loss, similar to that we see in that menopause slope, and these can lead to thinner bones over time. These medicines are often used for breast cancer when we are trying to lower estrogen levels to prevent the recurrence of breast cancer, or in prostate cancer therapy where the medications will significantly lower the testosterone levels along with male estrogen levels and cause new and significant bone loss. So for these types of patients who are at risk for aggressive bone loss, these are the types of patients that we would want to test for osteoporosis sooner. So how do we measure bone density? The most common mechanism and gold standard way to measure bone density is through the dual energy X-ray absorptiometry scan, also called a DEXA scan. The picture shows a DEXA scan here. It's a DEXA scan machine, and the scanner takes an X-ray, and it's able to quantify the density of our bone in certain key areas, like typically would be the hip, the spine, and sometimes the forearm. These are the areas that are most common sites to develop insufficiency fractures if osteoporosis is present. So the benefits of a DEXA is that it's very accurate and reproducible. A DEXA scan can precisely quantify the bone density of those areas. It also confers very little radiation. The amount of radiation that we would get that we would receive getting a bone density or a DEXA scan here, it's approximately equal to the amount of radiation one would get just walking around for a day in the ambient air. It's also 10% of what you would get with a chest x-ray. So minimal x-ray. There's other ways to measure bone density, including a quantitative CT scan or ultrasound. However, these are not the preferred ways of measuring bone density. CT scans are much more expensive and confers a much significantly higher radiation. And ultrasounds are cheaper, but they are not nearly as precise as a bone dense DEXA scan. And we generally will check monitoring DEXA scans every 1 to 2 years to assess for progressive bone loss and adequacy of treatment. So this is what a typical DEXA scan report looks like. It will give you your measurements at the spine and the hip, and these measurements are noted as Z or T scores. Sometimes the DEXA scan will include a score called a FRAX score that is used to identify patients with osteopenia or early osteoporosis who might be at much higher risk to have a fracture. The FRAX computation is based off of the DEXA scan score at the hip, along with several other risk factors that you can see here on the right in the box. And this helps your physician to identify whether or not you might benefit from treatment, even if you don't have osteoporosis, but might just have osteopenia or early stage osteoporosis. How do we interpret the DEXA scan report? So bone density determinations are all made by comparing a patient's bone scores relative to a young adult bone, like a 25-year-old bone. The measurements are reported as T-scores, and these scores will be a number between a positive and negative number. The numbers relate to standard deviations, or meaning how far above or below you are compared to a young adult healthy bone. So basically, a score between -1 and +1 is considered normal bone, and a T-score between -1 and -2.5 would be osteopenia or decreased bone density. And a T-score that's even less than -2.5, -3, -4, those are osteoporotic patients. Generally, the more negative the T-score is, the lower the bone density and the higher the fracture risk. In general, there are several medicines that can either minimize bone loss. These are called our anti-resorptive medications, or those that can help increase laying down new bone, which are anabolic medications. Every medicine has their own specific risks and benefits. So it's important to note that what might be a good treatment for one person might not be appropriate for another. Some of the medicines we use to treat osteoporosis include the class of medications called the bisphosphonates. These bisphosphonates are the most commonly used bone hardeners. They come in both pill and injection and infusion form, and they slow down the breakdown of bone, meaning they slow down the osteoclasts, allowing the osteoblasts to catch up. These medications include alendronate or Fosamax, risendronate, abandronate, zoledronic acid. Another medication, estrogen receptor modulators, are another class of medications that we can use to treat osteoporosis. These medicines include tamoxifen and raloxifene. They stimulate estrogen receptors on the bone. And incidentally, these medicines are often used in adjuvant therapy for breast cancers instead of aromatase inhibitors. And so for some patients at risk for bone loss, these are sometimes good choices for these types of patients. Denosumab is an injection of an antibody directed against a protein that is involved in the breakdown of bone called rank ligand, and this will decrease the amount of breakdown as well. All of those first three classes of medications will decrease the bone loss or minimize the bone loss, decreasing the osteoclast activity. So for the fourth one, though, the anabolic agents, these are the ones that will increase the osteoclastic activity. So these medications are reserved for the more severe osteoporotic patients and are used for only a maximum of 2 years. These include the parathyroid hormone injections and antibody injections, which is our newest medication called Evenity or Mosuzumab. And they can rapidly increase bone density for those patients at much higher risk for sudden fractures. Bisphosphonates and just denosumab, as well as the estrogen receptor modulators like tamoxifen, are the most common and preferred osteoporosis treatments that are used in the setting of cancer and cancer survivors. A large meta-analysis had compared Zometa, which is a bisphosphonate, to denosumab, and Zometa did show a slight increase in helping to prevent recurrence of breast cancer, certain breast cancers. So for some patients with a higher risk of breast cancer recurrence, your oncologist might choose to treat you with Zometa over denosumab, but they are equally as good or efficacious in preventing and treating osteoporosis. Not every patient will need lifelong osteoporosis treatment, so it's important to use our tools of monitoring DEXA scans. It's nice to note that studies show that once a patient is discontinued, often a aromatase inhibitor, that their initial increased bone loss can reverse back to their baseline risk. And as you can see, all these medications might have their benefits, but they can also include certain risks. So the best way to avoid osteoporosis is really by preventing it in the first place and trying to maximize our peak bone density early in life and slowing our bone decline as much as possible. And how we do this is through diet and exercise. Let's see. Patients that do need long-standing treatment are usually our patients that do have bone metastasis. They will usually be on lifelong treatment, or patients that might have a large load of PSA that need really severe androgen deprivation in prostate cancers, or persistent osteoporosis or aggressive osteoporosis with recurrent or high-risk fractures. As you can see here, there are several nutrients, including vitamins, minerals, electrolytes, proteins that are needed to maintain healthy bone. And most all of these are easily obtained in maintaining a healthy diet of whole foods. However, in order to treat osteoporosis optimally, it's really important to make sure that you're taking adequate amounts of calcium and vitamin D. Calcium is the main building block of healthy bone turnover. It's the most abundant mineral in the body and the principal mineral that makes that strong bone. And 95% of our body's total calcium content is in the bones. But calcium metabolism is complex, and if you don't consume enough, your body will start to take that calcium that it needs out of your bones, and ultimately it will worsen your bone density towards osteoporosis. The National Osteoporosis Foundation recommends a daily calcium intake for all men and women between the ages of 19 and 50 at 1,000 milligrams per day, and women above at 1,200 milligrams a day. Let's see, I think that's all this slide was showing us. So usually I try to tell my patients to get at least 1,000 milligrams of calcium a day. But try to do that in their diet as much as possible, because calcium is abundant in our foods. So most patients will be able to get at least half of their daily calcium allowance through their diet. And if they aren't able to, they might need to supplement just a little bit. So we try not to say take all of your calcium through supplements, but try to do as much as you can through these types of foods. And it's not just dairy, but you also have things like kale and sardines, almonds, soy, broccoli. So there's many foods rich in calcium. And so even just Googling high density or high foods high in calcium, you might be able to see that you're taking a lot of that 1,200 milligram daily recommended intake already. Okay, so vitamin D. So vitamin D is essential is an essential vitamin for our bone remodeling. It's necessary for bone growth and repair, and it allows our calcium to be absorbed in the intestine and put it into our bones. It prevents calcium loss in the kidneys, and it helps to regulate the phosphate and magnesium levels. Vitamin D deficiency can increase fracture risk, and this has been seen in studies showing that even just from the decreased function, neuromuscular functioning of vitamin D deficiency, this will increase your your falls, and it's also associated with vitamin D deficiency is associated with fatigue and muscle aches and general feeling of well-being. And so vitamin D is an essential vitamin in many respects. But vitamin D deficiency is also very common. So it's not unusual for most patients to need to take a vitamin D supplement. It's not readily found in food as much as calcium. And so you have to really try to put that into your diet as much as possible. Our skin produces vitamin D from the sun and needs to be metabolized and converted to an active form through our liver and our kidneys. And so these are just a few reasons why vitamin D deficiency is oftentimes very common. Let's see, our daily requirements for vitamin D between the ages of 19 and 70 would be 600 international units a day, whereas older than 70 years old, we recommend 800 international units a day. In treating osteoporosis, the 25-hydroxy vitamin D test is the most accurate way to measure how much vitamin D is in your body. And our optimal serum concentration that your doctor would get on a blood test would be between 30 and 50. So here are a few food sources that do have vitamin D. Mushrooms, tuna, spinach, egg yolks, salmon, a lot of them, cod liver oil. And so to get that 800 units, international units of vitamin D, you can see how it could be hard to get it in just your diet alone. So for patients who aren't able to get enough calcium or vitamin D in their diet, we do recommend supplementing. Popular forms of calcium supplements would be calcium carbonate and calcium citrate. Calcium carbonate is inexpensive. It does, however, need to be taken with food, and it needs stomach absorption acid for it to be absorbed. So patients that are taking proton pump inhibitors that decrease the acid in your stomach might not absorb calcium carbonate as well as calcium citrate. So also called Citracal. This is the more popular form of a calcium supplement, and this one can be taken anytime it's a little bit better absorbed. Just remember that the body can only absorb 500 milligrams of calcium at one time. So that's why we usually will say if you are needing to take a supplement, to take them in divided doses. So like with your breakfast and with your dinner would be better so that you can absorb it more efficiently. So calcium supplements in heart disease, I'm often asked about this because our cardiologists don't really want you taking supplements. And this was found in earlier studies back, I believe, in 2011 that did start to show that calcium supplements did seem to increase the risk of cardiovascular disease. So since then, not all studies have really confirmed this. So we're not, totally adverse to supplementing with calcium. However, because calcium is so readily available in our diet, we prioritize calcium through our diet rather than supplements. Supplemental vitamin D. So there are two common available forms of vitamin D to choose from, and both are equally absorbed well They're fat-soluble vitamins, so you do want to take this with a meal that does have some fat in it. And so patients are always asking, well, is D3 or D2 better? They're both just as good, but some studies do show that D3 is more effective at raising the vitamin D levels and maintaining your vitamin D levels in the blood better than vitamin D2. For vegans, they like to choose vitamin D2 because it is plant-based from yeast or mushrooms, whereas the D3 vitamin, or the cholecalciferol, that is from an animal product. So treating vitamin D deficiency, well, the Endocrine Society recommends that under 20 vitamin D serum blood level, we would take a daily 6,000 units or a once weekly 50,000 units of vitamin D for 8 to 12 weeks. What we want to do is we want to target a serum vitamin D level between 30 and 50. But optimally, in some studies, it shows that some patients will really need more, like 50 to 80. I usually will target around 50 to 70 for patients. And a lot of my patients will need to take a 50,000 unit capsule once a week indefinitely to keep their vitamin D storage up. So lastly, just as vital to bone is physical exercise, most specifically weight-bearing exercises, because weight is what loads and stresses the bone. This is what signals the bone to turn over and make new healthy bone. So walking, jogging, running, stair climbing, these are all great ways of stimulating more healthy bone turnover and laying down new bone. Although biking and swimming are not classified as weight bearing, these are certainly great exercises for muscular and cardiovascular health. So if you're not really able to do a lot of weight bearing exercise, I would still say that that does give you some bone advantages. So in summary, I wish I could read this. I can't see half of my my computer here, but I'm going to try to read this out here. Bone is a dynamic tissue. It's constantly remodeling, and it's capable of building new bone throughout our lives. Osteoporosis is an asymptomatic condition that can lead to bone fractures and early osteoporosis. Bone health can be compromised by lifestyle choices, medical conditions, medications, cancer treatments, and these oftentimes lead to premature osteoporosis. Many nutrients can contribute to bone health, so it's best to eat a whole food diet. Vital to bone remodeling or building a new healthy bone is calcium, vitamin D, and weight-bearing exercise. And correcting your vitamin deficiencies alone may also be able to prevent fractures in itself. DEXA scan monitoring in the setting of endocrine therapy and hormone deprivation in certain patients can help to diagnose and treat osteoporosis early and prevent worsening of bone loss. And in cancer treatments related to osteoporosis, or those with osteopenia and aggressive bone loss and high fracture risk, several studies show significant bone health benefit, including pharmacological treatments like bisphosphonates, denosumab, and tamoxifen.